Good morning, everybody. I am Mrs. R.Bindhiya, Professor, Sri Balaji College of Nursing. Today, we will discuss a topic called neonatal bilious vomiting from pediatric nursing. Neonatal bilious vomiting objectives: to discuss the differential diagnosis of biliary emesis in neonates, to do appropriate workup to confirm the diagnosis, to select the various treatment options, to make you confident in managing a newborn with bilious vomiting. Neonatal bilious vomiting causes: duodenal atresia or stenosis. So atresia is a blind, it is a narrowing which does not allow the content to pass through. So stenosis is the reduction in the diameter of the passage. And annular pancreas, malrotation and MGB, intestinal atresia, jejunal and ileal atresia, meconium ileus, meconium plug, meconium peritonitis, necrotizing enterocolitis, Hirschsprung disease, a very well-known disease, that is absence of ganglionic cells in the colon leads to Hirschsprung disease, where the child suffers from abdominal distension, inability to pass meconium, and shock syndrome thereafter. Anorectal malformations, rarely mesenteric cyst and intestinal duplication, incarcerated inguinal hernia. So these are the various causes leading to neonatal bilious vomiting. So bilious vomiting is something which is very serious. It should be looked into very quickly. It can be duodenal or annular pancreas, or it can be due to some malrotation or intestinal, jejunal or ileal atresia or anorectal malformation. So we have to keenly observe the child, the signs and symptoms, and do diagnostic evaluation as early as possible. Neonatal bilious vomiting, the other causes can be listed down into mural causes, extrinsic causes, and intraluminal causes. The mural causes may be duodenal atresia or stenosis, jejunal or ileal atresia, Hirschsprung's disease, necrotizing enterocolitis. So the mural reason is pertaining to duodenal atresia and duodenal stenosis. Jejunal or ileal atresia, Hirschsprung disease, and necrotizing enterocolitis. All these are put under mural. Second one is extrinsic, that is malrotation and MGV, mesenteric cyst and duplication cyst, congenital band like VI duct bands. So these bands also will restrict the movement and will lead to abdominal distension and inability to pass the stools and thereby worsening the conditions. Intraluminal causes, like we have meconium ileus, meconium plug, meconium peritonitis. So when the meconium is not passed for a longer time, it will lead to meconium ileus, plug, and the inflammation can later on lead to peritonitis. Duodenal atresia or stenosis. What is duodenal atresia or stenosis? In the duodenum, there is failure of vacuolization and recanalization of solid cord state of duodenum at 7 to 10 weeks of intrauterine life. So in the intrauterine life, when the fetus is developing, during the 7th to 10th week, when there is no vacuolization and recanalization of solid cord, when there is failure, that will lead to duodenal atresia. Proximal stomach and duodenum get dilated and hypertrophied because of this maldevelopment. That is, within 7 to 10 weeks of intrauterine life, if this recanalization of solid cord state of duodenum is not happening, if vacuolization is not happening, then that will lead to proximal stomach and duodenum to get dilated and hypertrophied, leading to bilious vomiting in post-ampullary type. So failure to pass meconium leading to minimal upper abdominal distension, that leads to hydramnios in mother and Down syndrome in the children. So this is how mother will present with hydramnios when the child is having duodenal atresia, and also Down syndrome will be seen in the child. Duodenal atresia and stenosis. There are different types. The first type is membrane type. there are subdivisions under membrane type, that is A, simple, B, fenestrated, C, windsock anomaly. Simple, fenestrated and windsock anomaly are the membrane type of duodenal atresia or stenosis. The second major classification is complete mural discontinuity with connecting fibrous cord. So there is mural discontinuity with connecting fibrous cord leading to the duodenal atresia. The third one is complete mural discontinuity without connecting fibrous cord. So this is a very serious type, that is complete mural discontinuity without connecting fibrous cord. It leads to complications. So we have to furiously diagnose the child. Duodenal atresia and stenosis, the types are classified in this diagram, A, B, C. Here you can see to what extent the duodenal atresia is. Now, in the diagnostic evaluation, how does the workup look like, duodenal atresia or stenosis? First, you can see through the antenatal ultrasound sonography of the abdomen, you will see a double bubble appearance. You can see there are two places where you can see the bubble appearance is there, that is which is called double bubble appearance, and postnatal X-ray and classical double bubble appearance, which is shown in the arrow mark here. So duodenal atresia or stenosis will classically represent as a double bubble appearance. Now, Kimura's diamond-shaped duodenostomy. So this Kimura's diamond-shaped duodenostomy is the one that we see where you see the proximal and then the distal. Here also we see the proximal and the distal part, which is separated, and then anastomosis is being done, suturing is being done. You see, this is how it is done. And the duodenal atresia, that is windsock anomaly. Here we see different pictures where surgical procedures are being carried out. That is duodenal atresia, the windsock anomaly. Now, duodenal atresia, the post-operative care. What kind of post-operative care should we give to the patient? Dysmotility due to megaduodenum may require a period of transplacental parenteral nutrition. So we give IV fluids and then parenteral nutritions are given as long as the patient is smoothly progressing. And anastomotic feeding tube may obviate the need for TPN, and graded introduction of enteral feeds as bowel motility requires. So we have to keep the patient on enteral feeds so that the patient can recover gradually. Prophylactic antibiotics for 48 hours. Of course, there is a chance of inflammation, infection, because the patient has undergone surgery and already the patient's immunity will be very low. The patient's nutrition needs may not be completely met. So we have to maintain the immune status of the patient by means of transparenteral nutrition. And also we are giving this transanastomotic feeding tube to obviate the need for TPN, and then we have to put the patient on antibiotics and cover the patient with the antibiotic circulation and keep the patient away from all types of infections. Now, annular pancreas was the second cause that we had seen. A rim of pancreatic tissue encircles second part of duodenum. So the encircling is a defect that happens in the duodenum that does not allow the passage of food to go through. So the annular pancreas is another cause for neonatal biliary vomiting. So a defect in rotation and fusion of ventral analgae with the dorsal analgae of pancreas. So clinical picture and radiological findings are akin to duodenal atresia. So we have to immediately put the child on diagnostic evaluation and find out where is the defect and clear it as early as possible. Because it is a defect in rotation and fusion of ventral analgae with the dorsal analgae of pancreas. So treatment also same as that of duodenal atresia. So in that we had seen, we had given transparental nutrition, and then we had put on the external feeding, and then we had given antibiotics for 24 hours. So all this will be done. The patient will be taken care in an intensive care unit in an 1:1 ratio, one patient, one nurse ratio, and the patient's input-output chart will be maintained. The patient will be kept under immobilization. The patient's back will be given care properly so that the patient does not develop any bed sore. Then the patient's basic needs will be taken care. Personal hygiene completely from back care to back rub to changing the position of the patient every once in 2 hourly, then checking the TPR and the vital signs. All that will be done once in every 4 hourly, and there will be a circle of doctors visiting the patient every now and then to check the input, output, and the proceedings of the patient. Now we see the annular pancreas, how it is being surgically repaired. So this is pre-duodenal portal view. On the top, you see the portal vein, and then you see the duodenum. So this is how it's being visualized. And malrotation, the embryology of malrotation here is that shown in picture A, B, C, and then D1. Here, how between the cranial limb and the caudal limb there is a malrotation, and then here you see the defect which is carried out throughout the intestine, and then the defect is seen in the lesser omentum. So this is how the defect takes place, malrotation. Physiological umbilical hernia and fetus is another cause for neonatal bilious vomiting. Now we see a table showing embryological intestinal development that is leading to malrotation and clinical presentation of malformation. So here we see embryonic intestine blood supply organ stage 1, gestation week 4 to 10, and 2 gestation week 10 to 11, and third stage gestation week 12. So foregut, that is celiac trunk, midgut. So here the superior mesenteric, the foregut is midgut and superior mesenteric, stomach, duodenum, ileum, jejunum, proximal, colon. And in the gestational week 4 to 10, we see physiological umbilical hernia and omphaloceal and laparoschisis. Whereas in the gestational weeks 10 to 11, we see retraction of umbilical hernia, cecum, that is 270 degree. So it is classified as 1A, 2B, 3D, 3C, and 4D. Now gestational week 12, normal is colonic fixation, whereas malformation is mobile cecum. Now hindgut is inferior mesenteric, where we see distal colon and rectum. Now non-rotation means failure of the normal counterclockwise, that is CCW, rotation of the midgut. The duodenum and small intestine remain in the right abdomen, the cecum and colon on the left. Whereas malrotation 1 means arrested counterclockwise rotation at 180 degree. The cecum typically resides in a subhepatic position in the right hypochondrium. The duodenojejunal flexure to the right of the midline and the superior mesenteric. Now malrotation 2 is rotation of 180 degree CB, that is clockwise, in one plane and 180 degree CCW in the other. The colon is behind the duodenum and the superior mesenteric artery. Hyperrotation, that is rotation more than 270 degree CCW. The cecum is in the left abdomen near the spleen. So in all these things we have understood that the failure can be like non-rotation, due to non-rotation where there is failure of normal counterclockwise rotation of the midgut. Second one is malrotation 1, which is arrested counterclockwise rotation at 180 degree. Malrotation 2, that is rotation of 180 degree clockwise in one plane and 180 degree CCW in other. This usually occurs in colon. Whereas hyperrotation is a rotation more than 270 degree, that is CCW. The cecum is in the left abdomen near the spleen. So you see the non-rotation occurring in the midgut leads to fault in the duodenum and small intestine in the right abdomen, and the cecum and colon on the left. Whereas when malrotation 1 occurs, it occurs typically in the cecum. That is, resides in subhepatic position in the right hypochondrium and duodenojejunal flexure to the right of the midline and superior mesenteric. Whereas when it is malrotation 2, it is occurring in the colon, which is behind the duodenum and superior mesenteric artery. Whereas hyperrotation is occurring at more than 270 degrees CCW. The cecum is in the left abdomen near the spleen. So these are the kinds of defects that are leading to malrotation. Now malrotation, different degrees. See here you can see diagram A, stomach, B, site of duodenal obstruction shown here, that is volvulus, twisting of intestine. Volvulus, twisting of intestine shown here, and there is duodenal dilatation. In C, we see superior mesenteric artery that is compressing the transverse colon. We can see the superior mesenteric artery is compressing the transverse colon. And here we see the liver and cecum and appendix here. And the next diagram shows internal hernial sac and the duodenum here. Here we see the duodenal obstruction and the volvulus of large intestine here. Volvulus of large intestine. So these are the things that we see in this diagram. Now malrotation. Any defect or deviation of normal midgut rotation leads to malrotation. So it can be a deviation of normal midgut rotation leading to malrotation. 60% of malrotation patients present in neonatal period. So malrotation patients will definitely present in the neonatal period, and that may be 60%. Most common type of malrotation is caused by Ladd's band due to arrest of rotation at 180 degrees. So because the degree of rotation is more, the Ladd's band is the most common cause of malrotation. And midgut volvulus is due to narrow duodenocolic isthmus. Duodenocolic isthmus. Now malrotation will lead to bilious vomiting, passing scanty meconium, upper abdominal distension, and in midgut volvulus, bleeding per rectum, abdominal distension, and vomiting are the classical signs. So we see bilious vomiting, passing scanty meconium, upper abdominal distension, and bleeding per rectum. If it is midgut volvulus, then it will lead to bleeding per rectum, abdominal distension, and vomiting. Now, malrotation imaging studies. How does the diagnostic evaluation present to us? It presents as a double bubble appearance, upper GI series. In simple malrotation, absence of C loop, DJ flexure, and jejunal loops on the right side of the abdomen. In MGV, corkscrew appearance is a classical sign, corkscrew appearance. In ultrasonography with Doppler scan, reversed position of SMA and SMB. So these are the imaging study findings. Malrotation imaging studies. Here we see two arrow marks showing the double bubble appearance. And in the right side we see corkscrew appearance. Again, malrotation imaging study showing absence of C loop and jejunum on right side. There is no C loop, and here we see the SMA and SMV shown in the arrow mark. It is a reverse position of SMA and SMV. Malrotation, the Ladd's procedure. So here there is division of Ladd's band and widening of duodenocolic isthmus. So because the duodenocolic isthmus is strangulating, there is widening of duodenocolic isthmus being done and division of Ladd's band. Malrotation with midgut volvulus. Here, derotation of volvulus. If bowel is viable, leave it. If bowel not viable, resection and EEA. If bowel viability is doubtful, second look laparotomy and complication short bowel syndrome. Jejunal and ileal ataxia due to mesenteric vascular accident during fetal life. Incidence 1 in 3,000 live births. Present within 24 hours with bilious vomiting, not past meconium and abdominal distension. Proximal obstruction. Earlier and more severe is the bilious vomiting. Distal obstruction, more severe is the abdominal distension. So due to mesenteric in jejunal and ileal, the mesenteric vascular accident during fetal life can occur. This is 1 in 3,000 live births. So it will appear very soon. Within 24 hours, the child will have bilious vomiting, not passing meconium, and abdominal distension. So the severity will be more. Whereas in distal obstruction, more severe is the abdominal distension. Abdominal distension will be more. Now, jejunal and ileal atresia, the types. Type 1, mucosal, that means membranous atresia. Intact bowel wall and mesentery. The bowel wall is intact with the mesentery. Type 2, cord atresia. Blind ends are connected by a solid fibrous cord. So there is a solid fibrous cord which is holding. So type 3A, gap atresia. So disconnected blind end atresia. A portion of bowel and its associated mesentery are missing, leaving 2 blind segments of bowel. Type 3B, apple peel atresia. Significant loss of bowel length and a large mesenteric defect. This is called apple peel atresia. Type 4, multiple atresia. Multiple atresias can be combination of type 1 to 3. So we have seen mucosal atresia, cord atresia, gap atresia, apple peel atresia, and multiple atresia. So in all this, we have seen the disconnected blind end atresia. In apple peel atresia, significant loss of bowel length and a large mesenteric defect is seen. And in multiple atresia is a combination of 1 and 3. So these are more complicated than the earlier ones. Here, jejunal and ileal atresia, you see the types in the diagrams. Diagram 1, 2, 3, and 4. Jejunal and ileal atresia. Jejunal atresia is a triple bubble appearance. And ileal atresia is multiple air fluid levels. Multiple air fluid levels are seen in this diagram. Jejunal and ileal atresia by barium enema and by unused microcolon can be visualized, which is shown in the arrow mark. Jejunal atresia, tapering jejunoplasty, end to back anastomosis. Here we see the end to back anastomosis being done. Jejunal and ileal atresia, operative techniques. These are some of the operative techniques: suturing being done, proximal and end to back, proximal and distal, Thomas taper, and typical operative findings. This is the proximal and the other side is the distal. These are the typical operative findings. Necrotizing enterocolitis, disease of paradoxes, unknown etiology. Most likely mechanism is vascular compromise to GIT resulting bacterial invasion of portal venous system. So it all begins with the bacterial invasion of the portal venous system. Common in premature babies, occurring during first or second week of life after starting oral feedings in babies weighing less than 1.5 kilograms. So the lesser the baby's weight, the more will be the complications. Distal ileum and right colon are commonly involved. So this is a disease caused by unknown etiology, common among premature babies, and between 1 to 2nd week of life itself, the manifestation will be seen. Necrotizing enterocolitis, a schematic diagram showing the immature epithelial cell layer and immature immunological defense, where we see the toxic injury, ischemia, hypoxia leading to mucosal injury. That leads to immature epithelial cell layer and excess formula substrate and bacterial overgrowth leading to immature immunological defenses, and excess formula substrate, abnormal flora leading to immature immunological defenses. Finally, that ends up with both immature epithelial cell layer and immature immunological defenses lead to necrotizing enterocolitis. Necrotizing enterocolitis, affected bowel, dilated with mucosal necrosis and subserosal collection of gas. So here we see the collection of gas and bilious vomiting, abdominal distension, rectal bleeding and or diarrhea. So you can have diarrhea, it may be with diarrhea or without diarrhea, but rectal bleeding is there. Abdominal wall edema, erythema, and fixed persistent loop of bowel. And we find pneumonitis intestinalis, gas in portal vein, and or free air in peritoneal cavity. So this is the major finding of necrotizing enterocolitis. Now let us see the modified Bell's staging for necrotizing enterocolitis. So stage 1 is suspected. Clinical finding is apnea, bradycardia, temperature instability. In stage 1 suspected, radiographic finding is gas pattern of mild ileus. Gastrointestinal finding is increased gastric residuals, occult blood in stool, mild abdominal distension. Now stage 2A definite. Clinical finding is apnea, bradycardia, temperature instability. 2A definite radiographic findings, ileal gas pattern with one or more dilated loops, focal pneumatosis. Gastrointestinal findings of 2A definite is grossly bloody stools, prominent abdominal distension, absent bowel sounds. Then stage 2B clinical findings, thrombocytopenia, mild metabolic acidosis, radiographic findings, widespread pneumatosis, ascites, and portal venous gas. Gastrointestinal finding, abdominal wall edema with palpable loops and tenderness. 2A advanced stage is clinical finding, mixed acidosis, oliguria, hypotension, coagulopathy. Radiographic finding, 2A advanced, prominent bowel loops, worsening ascites, no free air. 2A advanced gastrointestinal findings, worsening wall edema, erythema, and induration. 3B, shock, deterioration in laboratory values and vital signs. 3B, radiological findings. Pneumoperitoneum. 3B, gastrointestinal finding, perforated bowel. So the modified Bell staging for necrotizing enterocolitis summarizes the stage, clinical finding, radiographic finding, and gastrointestinal finding, where we see in 3A and 3B, which is advanced, where we see mixed acidosis, oliguria, hypotension, coagulopathy, prominent bowel loops, worsening ascites, no free air, worsening wall edema, erythema, and induration. We also see shock, deterioration in laboratory values and vital signs, pneumoperitoneum, and perforated bowel. So these are the complicated conditions. Necrotizing enterocolitis diagrammatic representation, where you see the arrow mark showing, and here naturally we see the enterocolitis. Necrotizing enterocolitis, pneumatosis intestinalis shown in the arrow mark, and here portal venous gas pneumobilia, which is shown in arrow mark. The management of necrotizing enterocolitis. Start aggressive medical treatment immediately. Keep NPO, NGT aspiration and TPN. Broad spectrum antibiotics. Physical, radiographic and ultrasonographic evaluation every 6th hourly for first 48 hours in NICU. Enterocolitis indication for surgery. Pneumoperitoneum and signs of peritonitis. Edematous and erythematous anterior abdominal wall, fixed persistent loop of bowel, portal venous gas, pneumobilia. Portal venous gas is called pneumobilia. Sudden deterioration of baby during medical treatment. So these are the indications for surgery when there is pneumoperitoneum or signs of peritonitis, edematous or erythematous anterior abdominal wall, or when there is a fixed persistent loop of bowel or portal venous gas. In all these conditions, these are indications for surgery. Necrotizing enterocolitis surgery. Operative strategy depend on extent of involvement of bowel. If perforation is small, direct suture closure or resection and primary anastomosis is adequate. In extensive bowel necrosis, remove all gross gangrenous bowel and do enterostomy. In doubtful bowel viability, second look laparotomy. In low birth weight infants with poor general condition, do just peritoneal drainage. So now we understand when there is an operative surgery, perforation if it is less, direct suturing, and primary anastomosis. In extensive bowel necrosis, do enterostomy and remove all gross gangrenous bowel. In doubtful bowel viability, second look rhabdotomy. And in low birth weight infants with poor general condition, peritoneal drainage. Now let us see the neonatal bilious vomiting, their history, physical, plain X-ray, contrast, diagnosis, and treatment. To summarize with, so we will see only two of these schematic diagrams. So first, when we see in the history, bilious vomiting, not past meconium, maternal hydramnios. Physical, upper abdominal distension, VGP Down syndrome, plain X-ray, double bubble appearance, contrast studies, barium meal, duodenal obstruction, duodenal atresia, or annular pancreas. The treatment for the first one, bilious vomiting, not passing meconium, maternal hydramnios, is Kimura's diamond-shaped duodenostomy. So when a child presents with the bilious vomiting, not passing meconium, and the mother is having maternal hydramnios, physically we have to look for the upper abdominal distension and the presence of VGP or Down syndrome in the child. And when there is an X-ray, we have to classically look for the double bubble appearance, which we have seen in the above pictures. We had seen when there is meconium is not being passed, and when X-ray is done, we see there will be double bubble appearance. Now, when we do barium meal, that is contrast studies, we have to look in for duodenal obstruction. And the diagnosis will be duodenal atresia or annular pancreas. The treatment for duodenal atresia or annular pancreas is Kimura's diamond-shaped duodenostomy. So we had seen the pictorial representation of Kimura's diamond-shaped duodenostomy. Now let us see the second type of condition, that is bilious vomiting, infrequent passage of small amount of meconium. Physically, what we see is upper abdominal distension. In the first case, we had seen upper abdominal distension, VGP, and Down syndrome. Here we see upper abdominal distension alone. Here in plain X-ray, we may see double bubble appearance and paucity of gas in distal bowel. So one extra symptom which is added to this is the paucity of gas in distal bowel. On doing the contrast studies, we find by barium meal absence of C loop. The C loop is missing, and duodenum corkscrew appearance will be seen. So in the earlier pictures, we had seen what was the look of a corkscrew appearance, and also how does it look when there is no C loop. So in a barium meal, we will classically find this. So when the barium meal study says absence of C loop and duodenum corkscrew appearance, it indicates malrotation and mid-gut valvulus. When there is duodenal corkscrew appearance, we can anticipate for mid-gut valvulus. And the treatment will be LADS procedure. We are releasing the LADS band, that is LADS procedure. We had seen in the earlier pictures, the pictorial representation, we have seen different types of malrotation. How does it look like? What are the causes? And how do we treat it? What is the post-op care? So LADS procedure. Then in mid-gut volvulus, we have seen derotation, resection, and anastomosis. So we had seen different levels of malrotation. Some were even more than 180 degree. So in such cases, the surgical procedure like derotation, resection, anastomosis will be carried out. So this is all about the different history collection, physical finding, the X-ray finding, contrast studies, and the confirmatory diagnosis, and the appropriate treatment done to neonates to rescue the child when the child is having neonatal bilious vomiting, abdominal distension, lack of passing meconium, and worsening conditions where the vital signs are not stable, the child's condition is further deteriorating, the blood sample results are not stable, they are not appropriate to the gestation, have the correct level, normal levels are not met. So when this is the situation, we have to do the diagnostic procedure and find the cause and immediately treat it. When the study for barium mean shows diurnal obstruction, we have to anticipate for diurnal atresia or annular pancreas, confirm it, and go ahead with Kimura's diamond-shaped duodenostomy. And when we find out there is barium mean, we find absence of C-loop or duodenum corkscrew appearance, that indicates malrotation and midgut volvulus, for which for malrotation, Latz procedure, and midgut volvulus, derotation resection and anastomosis. So we conclude the diagnosis on the basis of the contrast studies and the X-ray and physical examination, and also on the basis of history, and come to a conclusion. And with proper explanation and getting consent from the parents, we prepare the child and we carry out the surgical procedure and give post-op care to the neonate. And we counsel the parents so that they can take care of the child well at home and come for follow-up. So this was all about neonatal bilious vomiting.